So we're ready to get started. Welcome to today's lightning talk session. We're very excited to be welcoming 6 presentations here today. The format of this is they will each be 5 minutes long, and then there will be around 3 minutes for questions after each presentation. So you can ask questions via the Whova app. So you should see an Ask a Question button on the right-hand corner of your screen. And please send in your questions during the presentations so that we can immediately start asking them after the presentations finish. And if you like any of the questions that are coming up that you see in the QA box, please give it a thumbs up. And I will try my best to ask the most popular questions first. And also, if your questions do not get answered in our live session, presenters can also type out responses in the QA box on Whova. There will be one winner from today's session, and the prize will be an invitation to present a workshop at next year's conference. And the winner for this will be announced at the daily wrap-up at 3:45 p.m. To vote for this, you can click on the polls option on the right-hand side of your Whova screen and vote for your favorite talk. So without further delay, we're going to begin. So our first presentation is titled Association of Opioid Agonist Treatment with All-Cause and Cause-Specific Mortality Among People with Opioid Dependence, a Systematic Review and Meta-Analysis. And this will be presented by Thomas Santo Jr. So whenever you're ready, you can begin.
Cool. Hi, everyone. My name is Tom. I'm a PhD candidate at UNSW Sydney at the National Drug and Alcohol Research Center, and I'm presenting on a systematic review and meta-analysis that was published earlier this month in JAMA Psychiatry. So people with opioid dependence are about 10 times the risk of all-cause mortality compared to the general population. This is from a systematic review and meta-analysis that was also published in JAMA Psych last year by Farrell et al. We know opioid agonist treatment is effective in effective treatment for opioid dependence. However, coverage is relatively low given the public health burden. A previous review from 2017 found that overdose-related and all-cause mortality is lower among people with opioid dependence. So the goal of the current review was to search for new studies that have come out since then and update those results, but also look at other causes of death among people with opioid dependence. So we aim to update the review from 2017 and also review results from RCTs and observational studies that were conducted in different settings, and then also look at participant and treatment characteristics associated with variants. So we found that randomized controlled trials were largely underpowered for measuring all-cause mortality and the effect of opioid agonist treatment. Only 40 deaths total reported. This compared to 36 cohort studies and about 750,000 participants, only 5 of which came from North America, which may not be proportionate given the harm across the world, and mostly from people in and out of methadone treatment. We found that risk of death was about half that for people that were receiving opioid agonist treatment compared to those who were not, and rates of all-cause mortality were lower in methadone and buprenorphine treatment. We found that across participant treatment and study characteristics, there was a significant effect for people that were in opioid agonist treatment, and all-cause mortality was lower for all different groups, as we can see here. There was a lower risk of also other causes of death other than overdose-related death, so suicide, cancer, alcohol-related death, cardiovascular-related death, and drug-related mortality. The strongest association was with unintentional opioid deaths, and those are a subset of the drug-related mortality. For time periods in and out of opioid agonist treatment, the highest risk of mortality was during the first 4 weeks after someone leaves an opioid agonist treatment episode. The remainder in treatment, so after someone is in treatment for more than 4 weeks, is the lowest risk. And there was a slightly higher risk of mortality compared to the remainder of time in treatment during the first month of treatment induction. We also found lower risk of all-cause mortality in during incarceration. However, there was only one study that reported this, and people who were allocated to treatment after incarceration were also at lower risk of all-cause mortality. And that was regardless of whether they remained in treatment or not. And these studies, two of them followed people that were in and out of treatment following incarceration, and we found a significant reduction in mortality as well there. So overall, a strong, very strong relationship between remaining in opioid agonist treatment and lower risk of mortality. Multiple causes of death were lowered during opioid agonist treatment, and these results were significant across participant study and treatment characteristics. Increasing access and coverage of OAT for people with opioid dependence will hopefully reduce mortality amongst the population. And we also hope that we can increase strategies to increase retention and lower rates during the first 4 weeks after people leave treatment. So the strength of results, kind of went over that before, but given we can't really do RCTs anymore, given the ethical considerations there, we're confident in these results. And for future studies, more studies that are conducted for people who are incarcerated and those that recently leave incarceration are needed. Here's a disclosure of interest. Nothing related to the funding or scope of the study was there, but yeah, we hope future studies are able to continue to improve retention and lower rates of mortality for people with opioid dependence, especially related to drug-related deaths and overdose. So that's it, and thanks everyone for listening, and the full articles in JAMA Psychiatry published last month. Thank you.
Great, thank you so much for your presentation. So I don't see any questions currently in the chat, so feel free to add them to either the Whova chat or I guess the Zoom chat here.
People think of anything afterwards, more than welcome to email me, t.santo@unsw.edu.au.
Okay, so maybe if there's no questions, we will move on. And yes, if you think you have questions, you can email them, or also you can always add them to the Whova chat, and the speakers can answer through that at a later time as well. Well, thank you so much. Okay, so the next presentation we have is called Collective Care, Traditional Wisdom in Modern Times, and this will be presented by Len, Pierre, and Jordan White. So feel free to begin whenever you're ready.
Hi, everyone. Thank you. Hi, I'm Jordan White, and this presentation is intended to be decolonizing in nature and led by Indigenous people who have knowledge, wisdom, and experience in traditional teachings and ways. So it's a great honor and privilege to have Len as a friend and a co-presenter here to share this gift and this message for this presentation. So Len, please take it away.
Hi, Chika. Thank you, Jordan, my friend and colleague. And Ace-Whale, good day, everybody. Welcome. My name is Len Pierre. My ancestral name is Palikulak, and I am Coast Salish from Katzie First Nation. And I'm here today to hold a little bit of space for a very short period of time to talk about what I will call some lessons learned with an Indigenous perspective on the topic of the overdose crisis here in British Columbia, Canada, as well as substance use and addiction in times of crisis. And I think, very related to the topic and the title of this lightning talk is, why traditional wisdom in modern times? And I think it's very important for each and every one of us, and very much tying into those of you who are watching Dr. Gabor Mate's talk, we do operate in a society that has a lot of systems that scaffold this country that are ultimately fundamentally flawed, that are deeply rooted in colonial ideology and colonial values that perpetuate harm against not just Indigenous people, but people who belong to targeted and marginalized communities. So whether you identify as a woman, a person from the Black community, or the Asian community, South Asian community, a newcomer to Canada, a person with a disability, or a person who used substances. Our colonial systems, healthcare, justice, education, and the Ministry of Children and Family Services are all scaffolded by colonial values and ideology that perpetuate harm against marginalized people. But never do we ever get the time and space to hold a mirror up in front of our entire systems that scaffold this country and say, hey, it's not like what we're doing in our professional practices or the latest and greatest in scientific health research around, substance use and the overdose crisis. It's the systems that are designed, that scaffold society, that actually let this crisis continue moving forward. And I think that the emphasis of this lightning talk is to inject a pause into this moment and say, it's not just us and the onus is on the individual, because we know that doesn't work, that we need to take a step back here and see the systems that scaffold this state violence against targeted and marginalized populations. And I say that lightly and with humility, but also in unity and solidarity as an Indigenous person with my co-Salish hat on, with people in active substance use, in active addiction, and everybody who has been impacted by overdose, and everybody who is actively working in this line of work. So in just the last couple of minutes, that's the why. That's why traditional wisdom is necessary to mobilize in a time of crisis. Because there's this amazing quote by Audre Lorde who says, the master's tools will never dismantle the master's house, meaning that we cannot talk about reversing the overdose crisis with the exact same thinking and mentality and values and cultures that reinforced it and created it in the first place. Capitalism, white supremacy, targeted violence, all of these things, colonialism, really, perpetuated where a lot of these kind of harms come from. So I'll just share with a couple of lessons that we've learned over the years in making those kind of connections and holding up that mirror in how we want to respond as First Nations communities in this province. Number one, we wanted to go away from prohibition. We know prohibition doesn't work. So actually, rather than to de-emphasize our focus on prohibition, we wanted to emphasize our approach on cultural connections, cultural identity, and cultural safety for Indigenous peoples who are accessing healthcare services, harm reduction services, and anything substance use programming. Number two, we wanted to depathologize peoples. We hear things like user, addict, substance use disorder, substance abuse, substance misuse. We have since started to move away from those conversations because they're so pathologizing to the people whom this topic matters most. And we as Indigenous peoples, have really have a strong relationship by being over pathologized, which really just removes the systemic, discrimination and racism and harms, colonial harms that continue to exist within today. And lastly, I'll say it and then I will stop for the last lesson learned because I'm out of time, is, it's not just trauma-informed practice. It is trauma and resiliency-informed practice because, and this is coming from our friend and comrade who does great social activism work, is, we're not motivated by, people's experiences of trauma and violence and torture. We are motivated by people's resilience and resistance to get up and fight every single day to live and to survive and to create more opportunities for fellow comrades in the community. So with that, on behalf of Jordan and myself, we say Haitsep Kasiyam and raise our hands to each and every one of you for being here. And thank you.
Thank you so much for that presentation. I think it was such an important topic and you did a great job communicating that in such a short time. So we have a couple questions here in the Hova chat. So the first one is how to help the public prioritize addiction and trauma-based knowledge.
Go for it, Len.
How to help the public prioritize addiction and trauma-based knowledge. I think that, again, there is this subtle observant and almost voyeurism that happens in society by, we continuously other people. Well, those people are addicted. Those people are using substances. It's not me. It's not my family. Again, we need to, tackle the systems that perpetuate the harms. So our education system, we need to reform all kinds of education and training that is respectful and self-determination and harm reduction and trauma and violence informed much earlier on. Again, with rethinking about how we're thinking about enforcement and decriminalization. Again, these are like approaches that we need to, I forget the terminology that Dr. Gabor-Mate used. Evidence-based politics is what we really need to go after, because the evidence is there. We know what needs to be done. It's the society and public that we kind of need to take on, and we need to really start emphasizing and putting our backing behind these key decision makers and influencers to help mobilize. But I will also say we need some drastically reformed community-based programming too, because a lot of our community programs are still oriented in this is your brain on drugs and with the egg in the frying pan, which we know doesn't work. We need some drastically transformative education around substance use, trauma, addiction, and overdose. So it's rethinking a lot of those sustainable program areas, I would say.
Yeah, that's a great answer. So we have another question here. So what are effective ways to communicate the need for traditional wisdom to people who might not understand this concept?
Mm-hmm. The first part is admitting that we have a problem. And that the problem is not on individuals. It's not on a demographic. It's not on a specific behavior. The problem is scaffolded within this country. Again, back to we have systemically flawed systems, education, healthcare, the justice system, social services are all rooted in colonial ideology and colonial values that serves a very small portion of this and the population in this country. And what we need to do is start acting in solidarity and unity with one another, which thanks to the magic of technology in today's day and age, Black Lives Matters, Me Too movement, we're able to share and act in solidarity and unity with one another. But we need to be able to feel comfortable in calling it what it is. We have a colonization problem. So where we can start is decolonizing our attitudes and our mentality and our worldview on the world, and really start seeing ourselves as a global citizen, and not just a citizen in our work practice or our communities, but more in a global environment, and see how we are actively contributing to, whether we're passive or we're an activist against it, how are we all contributing to this scaffolding of the country that continues to perpetuate this harm? And then whatever sphere of influence you have, to mobilize your own activism in your own sphere of influence. And I don't care if you're like a single mother of 3 children, that's a sphere of influence. I tend to live a very big life because I speak publicly and teach for a living. So I have a much larger sphere of influence. If you have a Twitter account, if you have a Facebook account, it's just dropping those language and those concepts into the greater public to start that shift and start peppering some new ideas, new perspectives, new strategies for moving forward.
Great. Well, thank you so much for that. And that's great advice for everyone. Okay, so moving on to our next presentation. So this is titled Patterns of Post-Discharge Opioid Dispensing Following Cesarean Delivery in British Columbia, Analysis of Trends from 2014 to 2019. And this will be presented by Stefanie Polderman. So whenever you're ready, Stefanie.
Okay, hello everybody. Sorry for the long title. So my name is Stefanie Polderman, and this is a talk on post-cesarean delivery opioid prescribing in BC hospitals from 2004 to 2019. Just waiting for the next slide here. So our multidisciplinary team includes experts in the field of addiction, anesthesiology, and patient safety. So our goal was to look at opioid prescribing trends after cesarean delivery in BC over a large period from 2004 to 2019, using uniquely available PharmaNet data. So here are our disclosures. And first, just to provide some background on the study. So Canada has historically mirrored the United States trends in opioid prescribing. And so a recent study in the Annals of Surgery found 91% of patients in the United States were prescribed opioid medications compared to only 5% of the patients undergoing the same common surgical procedures in European counterpart countries. So as you can see on the left image with the green arrow, British Columbia currently has the highest rates of cesarean deliveries in all of Canada. As seen on the right, we also have the highest rates of opioid toxicity deaths in 2020. So our study looked at a population of roughly 135,000 women with the outcome of opioid dispensing 7 or less days after discharge, excluding patients with a prior cancer diagnosis or opioid usage in the past year. So we used the Canadian Institute of Health to classify 48 different BC hospitals into 4 categories: teaching, large community, mid-sized community, and small community. This slide shows the average percentage of patients dispensed opioids across BC. The overall average is shown by the red line, from 31% in 2004 to roughly half in 2019, as you can see. So as you can see in the red box surrounding 2008, there's a large decrease coinciding with that time period, showing a major shift in the trends. Figure 2 shows the average opioids dispensed in 6 hospitals with sudden and steep reduction. This reduction spans a time period of roughly 7 years, shown by the red box. Figure 3 shows the trends for 4 hospitals that had increasing opioid dispensing rates, while the rest of BC hospitals were decreasing. 3 of these hospitals were small community and 1 was mid-sized community. Figure 4 shows the opioid 4 classes seen in the hospitals just shown before. The red line shows the total average of these outlier rates increasing to as high as 66% of patients being dispensed opioids in 2019 in these 4 outlier hospitals. This is the same figure 4 where we focus instead on the yellow line representing tramadol drastically increasing, while the blue line representing codeine drastically decreases. Figure 5 shows the same opioid classes in the rest of BC hospitals for comparison. The red line shows the overall decrease that we were looking at before. Again, this is the same figure 5, and we can focus on the yellow line showing an increase of tramadol and the blue line showing a decrease in codeine, not as drastically as those previous outlier hospitals. So overall, we can see that the rates of opioid dispensing post-cesarean discharge are dropping. We noticed large changes coinciding with 2008, which then occurred over an unsynchronized 7-year period. These findings raise the question of what actually changes prescribing trends and how can we increase consistency across BC. And although we saw a decrease, rates in BC are still higher than international standards for opioid prescribing. As well, we were unable to assess unfilled prescriptions, dosages, and pain scores. So overall, tramadol is replacing codeine, and that shows us a need for specific consensus guidelines and more stringent monitoring. Finally, what implications does this have for the overdose crisis in general? We know that rates are falling, but overdose deaths are still rising. So thank you for listening to my lightning talk. And for any questions not answered in the next question period, please just email the address I have listed here.
Great, thank you so much for your presentation, Stefanie. So we have one question here in the chat. So we know that men and women use drugs in different ways, i.e. they start at different ages, reaching out for help at different times, etc. So how do you think post-cesarean opioid prescription rates impact the way women use drugs?
So typically, if we're looking at based off strictly sex, you are typically getting, and not gender, you're getting women who are having these procedures done. And so obviously we're looking at that population, and there have been studies showing that 1 in 300 patients receiving this opioid prescription post-cesarean do become chronic users. So I'm not sure if that quite answers the question there, but feel free to ask further follow-up.
Yeah, I think so. So another question we have here in the chat, does the higher than average opioid prescribing rates coincide with safe supply initiatives?
So I'm not really sure what the question's asking there, if they coincide. So are you saying that if the decreases in prescribing line up with the safe supply, or if someone could just clarify that question for me? I guess just to elaborate on our higher than average opioid prescribing, we have looked at surprisingly certain events such as the Health Canada warning against codeine in breastfeeding mothers, or the 2016 public health crisis regarding opioid overdose deaths. And we did see dramatic changes in the trends around those specific dates. We did not calculate, obviously, a causation, and we're just looking at more of a correlation there. But they were such large changes in the trends that it would be interesting to see how certain things such as the safe supply initiatives affected the public awareness and prescribing behavior regarding opioids post-cesarean section.
Great. Okay, so a couple more questions. What do you think is the next step to take to lower prescription rates to become more like those of different countries?
Yeah, so that's an interesting question. I think everyone is trying to figure that out, but a couple of different specific actions that we've identified would be to have more of a coordinated process across the province. So instead of each hospital having their individual programs, we could get sort of an expert consensus going on and sharing of pain programs such as enhanced recovery after surgery, or there's some nifty apps like the Panda Pain app that I think was just released recently that helps actually patients go through their opioid prescription journey and sort of what their expectations are, such as their pain management and how many pills they should be taking and where they store it. So really, I think there's a couple of areas that we can attack in the preoperative, intraoperative, and postoperative areas to get a more coordinated approach across BC. Because there are so many great initiatives going on, it just from what we have been able to decipher, it seems like they're quite scattered, and so affecting different areas differently.
Great. Well, thank you so much for your presentation, Stefanie.
Thank you all for listening.
Okay, so we are now going to move on to our next one. So this is titled The Great Amplifier, Opioid Overdose in Times of Disruption. And this will be presented by Rob, Johannes, and Samim Hasham. So whenever you're ready.
Thank you. My name is a tongue twister, but you did a really good job with that, Melissa. Thank you. So pandemics are system disruptors, and COVID-19 pandemic has amplified the disparities in the opioid overdose crisis. Rob and I will share some data, we'll discuss impacts on people who use drugs, and perhaps offer a master plan. Be ready to learn a new term and a policy idea. So pandemics have passports and they spread over continents. Epidemics are more in communities, but syndemics, they recognize that these two occur synergistically in the context of a pre-existing social and health condition. In Ontario, we led the country in opioid overdose deaths. For example, in 2020, Toronto had a 78% increase in confirmed opioid deaths compared to 2019. This is clearly a drug poisoning crisis. In the first 15 weeks of COVID-19, Ontario saw a 38.2% increase in opioid-related deaths. To put it in perspective, imagine 2 plane loads of people vanishing from society in 15 weeks. Unbelievable. The data also showed that strong clustering of opioid deaths in neighborhoods with the highest material deprivation before and during the pandemic, but there were more opioid deaths occurred in neighborhoods with higher ethnocultural diversity during the pandemic. The largest increases, of course, happened in individuals between 24 to 44, 45 to 64, same pre and post-pandemic. They accounted for about 89.5% of all opioid deaths. But 65 plus, we saw the rate doubling in individuals 65 plus. Now, we all know the context of dopamine. Drugs flood the brain with dopamine. They stimulate the reward system, producing an extreme reward state. What the brain does is it neuroadapts to this too much dopamine. And so addiction actually is a chronic disease and needs to be treated as such. What we've learned from past disruptions is that massive doses of fear, uncertainty, anxiety, depression, grief, they all have an impact on suicide, drug use, and overdoses. But this time we have the added complexity of social isolation. So what are we seeing on the ground? What are people saying to us? You know, their social structural conditions, unsafe, unstable housing, contaminated supply. This is all affecting our opioid overdose crisis. Is it time to have conversation about a safer supply and decriminalization? Perhaps we should. And then what are the solutions? Here are some solutions here. The one that I really want to talk about is health in all policy. And this is an evidence-based politics that Gaber talked about. So, you know, respecting charter rights, entrenching policies in housing, employment, access to healthcare. And I'm hoping to answer a question on that in the question answer. Rob.
Thanks, Samim. An old friend of mine named Dave died of a heroin overdose with an naloxone kit on the bed next to him. I used to think of that precisely as why we need supervised consumption sites, but now I think of how many Daves we've lost from isolation during a global pandemic. We've come to understand that the opposite of addiction is not sobriety, it's connection. And MRIs have shown that the same parts of our brain respond to love and inclusion as opiates and stimulants. Now, COVID-19 has amplified existing disparities internationally, and that's provided the opportunity to learn from best practice in countries that have far more experience with localized epidemics than we do. A global pandemic really requires a global solution. I've been involved in harm reduction since before it was a thing in the downtown east side Vancouver 20 years ago, represent. Harm reduction is a lot more about a lot more than just drug use, as a lot of us probably know. Now, when I was living and working in that 10-block radius of East Van, there were common threads of chronic pain and social exclusion. Service coordination was quite effective. Now, the city of Vancouver is 114 square kilometers. Toronto, where I endure now, has pockets of community spread out over 630 square kilometers. So this is not only social but massive geographic isolation. Toronto was home to a public health crisis declaration on anti-Black racism last year. St. Jamestown is the most ethnically diverse neighborhood and also the most densely populated community in all of Canada. It's highly economically ignored, but it's also extremely, extremely resilient, which harks back to what Len was talking about earlier. The pandemic has required us to redefine the parameters of crisis response to include epidemics and pandemics, as well as incorporate systemic interactions of what would otherwise be treated as interpersonal incidents, because like us, crises like this do not exist in isolation, nor do they sleep. So what we've really done here is we've compressed a 1.5 to 2 hour talk into just a couple minutes. If you'd like to follow up with us, here's our email addresses. We'd love to chat with you, but let's do that in the next couple minutes. If you have any questions, feel free to throw them out. Thanks for your time and thanks for having us here. It's nice to stay connected to my old homestead in Vancouver.
Great. Thank you so much for your presentation. So we have one question. Someone was wanting to know, is tramadol more addictive than Tylenol 3?
Samim, pharmacist.
I think that question might have been for the previous presenter. So Tylenol 3 has, but I'll take a jab. I don't know if the previous presenter is here or not, but there you go. She just put it in. That tramadol has recently been rescheduled as Schedule 1. And Tylenol number 3 has 30 milligrams of codeine. So tramadol definitely has a dependency, and hence the new regulation. And there you go. Oh, she's done the work for me. Whoever advised did the work for me. So thank you so much for that. Yeah.
Okay. So I guess maybe we have a couple other questions. So someone wants to know, how does the community level response of St. Jamestown differ from that of the downtown east side?
That's a good question. The thing is, I think the community of St. Jamestown is quite similar to the downtown east side. It's very densely populated. It's very analog. Word of mouth travels. The community is very actively involved in its own affairs. The thing, though, is that that's one community in Toronto. So there's so many pockets of those communities all over the place. And the challenge with Toronto is, how do we coordinate responses across so many different communities? So St. Jamestown is really kind of one of the shining stars in terms of how to coordinate crisis response. And we're really trying to set the template for how other communities across the city can follow suit.
And I think we have the usual, games of politics that play into the funding model in St. Jamestown and other areas of Toronto as well. And that adds to the complexity, right? Because everybody wants to take care of their little pocket that they're representing and not the totality. This is where this notion of health in all policies becomes so important, because if we think any policy that we make, whether it's building, having a huge building in the middle of, Toronto downtown or St. Jamestown, how is that going to affect everybody? If we have a school, put into the St. James community, who is it serving? Who are the people? Is their health accommodated for? So I think St. Jamestown is sort of like a microcosm of health in all policies, where they consider the totality of the population. And I think the work that Rob and his team has done there is amazing at the meso and the macro level, bringing the two together. So it's been quite an experiment.
Great. Well, thank you for that answer. I think that's all the time we have for questions. So if there's any other questions, feel free to put them into the Whova chat, and they can be answered through that, or just through the Zoom chat as well.
Thank you.
Okay, so moving on, our next presentation is titled Virtual Consumption, Love in the Time of COVID. And this will be presented by Oona Krieg.
Hi, everyone. This presentation was written on the ancestral and unceded overlapping territories of the Hulkaminam, Halkaminam, and Hunkaminam speaking peoples, including the territories of the Musqueam, Squamish, Stolo, and Tsleil-Waututh nations. We would also recognize the Whitsun, Katsi, Kwantlen, Coquitlam, Matsqui, Quat, Semiahmoo, and Tsawwassen First Nations, all of whom are members of the Coast Salish Nation, all of which are occupied by the municipality of Vancouver, the British province of British Columbia, and the government of Canada. And I recognize that we are uninvited guests on this sacred land. So let's talk about overdose fatality reports from across the continent are shocking, but not surprising. Public health regulations, mainly social distancing and quarantine measures enacted across North America, are directly correlated to a sharp increase in overdose deaths as in-person resources were defunded, shut down, or severely limited in their capacity to provide service. People who use drugs have looked out for each other and kept each other safe since long before government authority began funding innovations like supervised consumption sites and syringe exchanges. And the pandemic has likewise moved community groups to use technology to help address service gaps that put people who use drugs at increased risk. Let's take Insight, for example. Against all odds, in an act of extreme courage and community love, drug users and service providers fought for their lives in a Supreme Court battle to provide supervision services and received a federal exemption from Health Canada to keep Insight stores open. Since its inception in 2003, Insight has seen over 3.6 million visits and reversed almost 7,000 overdoses. But we still haven't seen a comprehensive uptake of this The harm reduction community waited with bated breath for the political uptake. And in 2003, that was in 2003. And to this day, there aren't any exempt or sanctioned sites in the US, and in Canada, they are precarious and being shut down all the time. We all know that supervised consumption sites are effective, efficient locations for life-saving intervention. And that being stated, using alone is the preferred method of consumption for many, and that isolation is still the main factor in overdose fatalities. With the barriers of stigma, social isolation, and inaccessibility, drug users and service providers have taken up another mantle, virtual supervised consumption. There are many virtual interventions developed and launched over the past 3 years. Smartphone applications and telephone lines are tools utilized by people who use drugs, not only to remain safe while using drugs, but also feel valued as human beings who happen to be drug users. And because supervision is critical during an overdose to summon overdose response, these innovations provide human connection and community activation at a critical moment. Typically, a caller will connect with virtual support through a phone line or application platform before they use drugs. Most applications and telephone-based supervision services are person-to-person calls where the caller stays on the line or platform with a trained supporter until the caller feels safe or the window of risk has diminished. However, one BC-funded innovation is an egg timer app with a direct link to EMS. And despite Good Samaritan laws, many drug users rightfully have concerns about police intervention if 911 is called, especially among people who use drugs who are racialized. 99% of calls are purely support. Less than 1% of calls result in the caller becoming unresponsive. And this is the time when community activation is critical and a purposeful and timely flow of information containing caller location needs to be disseminated to community response services quickly. People with lived, living, and shared experience around drug use and overdose prevention are key to supporting callers and tend to have the least influence on public policy decisions and design. Therefore, innovators and harm reductionists must build solutions by centering the voices of those impacted by the overdose crisis. At the end of the day, as you can see, virtual supervision works. So, what about life after COVID-19? Can witnessing technology be expanded to fill gaps in overdose prevention for rural and underserviced areas and marginalized populations? Can innovations like the Brave app or NORS or their siblings or descendants grow into trusted life-saving tools for millions of people who use drugs alone? The overdose crisis has no single answer. Universal access to a safe supply of opioids and other drugs is vital, and so is naloxone, and so is legalization and decriminalization. We hope to see a continuum of options and many, many networks of love that keep people who use drugs alive. Thank you.
Thank you so much for your presentation. So we have a couple questions here for you.
Excellent.
So the first one is that you mentioned some limitations of current safe injection site models. What do you think is the next step to improving them?
Well, the main limitation to site-based supervision models is that they are engendered inside of urban environments. So people who live in remote rural areas don't have access. So it only accesses a very small portion of the population. The other main issue is that most of them are injection use. So only 11% of drug users describe themselves as IV drug users. So that is an entire, there's an entire plethora of other types of drug use and drug users who won't access that space. So, if every little tiny community had an SES in it, that would be amazing, or an SIS, or and consumption routes were expanded into however it was that people use drugs, that would be great. Also, hours 24/7 would be amazing. Other than that, so can we turn people's environment where they are into a safer space is the question of virtual consumption.
Great, thank you for that answer. So we have another question. Are there any anticipated legal barriers with offering such an app?
Nope. There are our partners at NORS. So we co-founded and launched the National Overdose Response Service. We have liability across each of the provinces in line with the Good Samaritan Act. The act is not a law in itself, and it is applied differently in all of the spaces. Also at Brave Technology, we work in the US where there is no exemption and over-criminalization and racializing of drug users in those spaces. So we don't, again, I don't know if there's any liability for us to apply for in that context. At the end of the day, we're trying to activate community response. We're not so much worried about how litigious it is.
Great, Thank you for that. And I think that's all the time we have for questions here, but there is one other question I'll point out to you. Someone's asking about the Brave app, so maybe if you can answer that within the chat, maybe where they can find more information, that would be great.
Absolutely.
Great, thank you so much. Okay, so now for our final presentation. This one is titled Implementing Substance Use Simulation at an Urban Emergency Department, a Pilot Project. And this will be presented by Amelia, Birch, and Nat Brewer.
Hi, folks. My name is Amelia Birch. I'm a clinical nurse educator with the Regional Addiction Program for Vancouver Coastal Health.
And hi, I'm Nat Brewer, peer support worker at Hope 4, subcontractor with Vancouver Coastal Health.
We acknowledge and appreciate the 14 First Nations on which we stand within Vancouver Coastal Health, and we raise our hands for them being the traditional and current keepers of our land. So we go into this with open hearts and open minds and learning. So simulations are common in medical education to use as a safe and effective learning modality. Our sims are innovative because healthcare providers are given a familiar teaching strategy, but used with peers and for substance use. At a local urban emergency department, staff are noticing interactions with people who are using substances, and this was in the context of the overdose crisis and safety-related incidents. So we needed to upskill.
In February of this year, 4 simulations were developed based on real client experiences. They occurred over 4 consecutive weeks with increasing complexity, and didactic education sessions for staff were offered. In the youth focus scenario number 1, family involvement and harm reduction approaches for youth with a concurrent disorder were focused upon. In the second scenario, also youth focused, the focus was on caring for youth certified under the Mental Health Act and transferred from a rural setting.
Our third scenario was our on an adult focus scenario, which is engagement and screening of someone who is actively using substances. And our second adult focus scenario was assessment and treatment planning for someone who has complex care needs, including substance use, gender competency care, sexual health, and homelessness. Each simulation is about 1 hour long and includes a pre-brief, the practice by staff, a debrief, and an evaluation through a feedback form and survey.
And here we see the people with lived and living experience that were participants that contributed their time and their energy to this project. Participants were recruited through personal emails to services, peer facilitation lists, and by word of mouth from healthcare providers. They were offered training, orientation, and a debrief. They were compensated $25 an hour for participation. Efforts were made also in their involvement, full participation in the project. So they were involved in every aspect, collaborated to co-write scenarios, acted as simulated patients during in situ sims, and participated as co-facilitators in various aspects.
For our staff participants, we recruited through word of mouth, availability from frontline work, posters, and recruitment through the department. It included emergency department staffing, nurses, emergency room physicians, and allied health, educators from both the regional and local area. And we really believe that Annette Brown and her colleagues said it very well when we say disruption is learning. So we saw that this pilot demonstrated a rich opportunity to provide education. We had many successes. Peers and participants enjoyed the experience and found the simulations meaningful. It was feasible to implement with minimal resources and high output, and is replicable to other sites.
And from one staff participant, I did not experience anything negative. I wish we had more time to debrief. Some of the content is new and sparks rich discussion. And also the persons with lived experience had great benefits from this process as well.
So we did have some improvements that came that are needed from our results. We heard that we needed to focus on social issues as opposed to medical issues, that there needed to be more time overall.
And from one of the physician participants, I wish we had focused more on the trauma-informed care and approach to patients who are non-binary rather than the overdose. I felt I already knew the overdose stuff.
So in the future, we hope to be able to expand this project to other sites and modify to use in other units other than the emergency department. We're pairing it with video simulation training to increase competence and confidence. And we really want to be able to advocate for peers to be able to be involved at all levels of simulation training. So thank you for listening to our lightning talk. That was crazy. And we're just wondering if anybody has any questions. Happy to chat.
Great, thank you so much for that presentation. We have one question here in the chat. So what are the main differences between the youth and adult focused scenarios?
Yeah, so that's a great question. Three out of the 4 scenarios include folks who are under 24 years of age. And with 2 of them, we have scenarios for folks who are under the age of 19. So that ends up implicating a lot more conversation around family involvement, consent, and what does it mean to be accessing service as somebody who is young? Hopefully that answers, but the themes can be translated across all 4 of the SIMs with a lot of common themes of trauma and violence informed practice, harm reduction, and cultural safety and humility.
Great. Okay. Are there any more questions? Please put them in the chats.
We will also be pairing these simulations learning with a virtual learning strategy, which includes all 4 of the SIMs being hosted online on a video project, and we hope to present that in the future. And all our peers and have done some really excellent acting within these simulations. It's very exciting.
Oh, we actually have one more question here. So can anyone participate in the simulations?
Absolutely. So our simulations are focused to be adapted for folks in emergency departments, in acute care and tertiary care settings. And any staff are able to participate in them as they're available, yes.
Great. Okay, well, I think if there's no other questions, I guess as always, you can continue to add them to the chat and the speakers can answer them afterwards. Thank you so much for that presentation. And that actually brings us to the end of our lightning talks. So thank you so much, everybody, for all of those wonderful presentations. I think it's so impressive to be able to pack so much information into such a short period of time and then answer questions about it afterwards. So I think you all did a really great job. Just a reminder to please vote for your favorite talk. So this will be in the poll on Whova and it'll be kept open during the next break. So please do that right away. Also, recordings will be posted on Whova as well soon, and we'll be moving